Hello, my name is Mariana Veríssimo, and I've been working with supported living for over 2 years. And like Lizzie said, we're going to talk you through the 21-day challenge that we did last year.
So what we knew going into this challenge was that excessive weight gain in the learning disability population was quite high, and the prevalence of obesity is very high in this population. And this is a problem because there are lots of conditions associated with this, such as type 2 diabetes and heart disease, and these all contribute towards a lower life expectancy in this population group.
Saying this, we know that some genetic conditions such as Down syndrome are more predisposed to develop obesity. The risk of obesity further is enhanced by the behavioral background, biological, physiological, and or social factors. As well, we can include the cultural backgrounds. For example, we have 2 service users at supported living. I can talk you through about one. He was born during the war. We believe that at that time they only had jam sandwiches, for example. So that's the only thing that he will happily accept to eat. Regarding, for example, behavioral, we have a lady that she sees herself as a housewife, which is nothing wrong with that, that's totally fine. But because she behaves like that, sometimes her behavior towards food is quite challenging. So sometimes that is another challenge for the staff to handle. And then a lot of people say that because people have a learning disability, they are not so capable of losing weight, which we don't believe. We believe that everyone is capable of losing weight. With the help of health professionals and support workers, we can help them to achieve a healthy and controlled weight loss. Because we have a motto at Supported Living, and we really believe in this. Even a small change on weight is still a big change. And if we all help the service users to achieve this, this is a big thing for them.
So we know that carrying excessive weight is a problem. So why does this matter to us? So in supported living, a large proportion of our service users are overweight or obese, over 60% in fact. Because a lot of these people are supported by us for dinners and for their activities, we would expect them to be offered healthy meals and opportunities for exercise. So we would be expecting them to move towards a healthier weight. But unfortunately, we haven't seen this. And actually, since people have joined the supported living team, their weights have stayed very stable or have actually increased. So just some examples of that. Of the 6 service users that we sampled, all of them had increased weight since they joined our service. So these figures range from a 12 kilogram increase up to a 42 kilogram increase in one service user. And if you can just go to the next slide, there's an example here. This person joined at 122 kilograms. So it's important to emphasize that they were already overweight when they joined us. So it wasn't a problem that we created. And they actually increased to 143, which is 22 stone, and that classes them as extremely obese in the BMI scale.
Saying this will associate with the excessive weight. We will associate some risks. It's supported living, we can see most of them, like the type 2 diabetes, heart disease, hypertension, all the way down to kidney disease. Something we have not yet observed is the cancer, but if it's not something that we help them to control now, it's something that we will possibly see in the future. So it's our job as support workers to help them to overcome this.
So with all this in mind, we were suggested by our team leader, Mary Claire, who's not here today. She told us about some research from the Public Health Collaboration, and that's where you can reset your metabolic rate within 21 days. And that's if you follow healthier meals for those 21 days, that can start some initial progress, and then it's up for the staff to maintain that progress with service users. And we wanted to put in guidelines that all of the staff can follow, whether they work here once a month on bank shifts or if they're there regularly. They can all follow these guidelines and help them keep that initial progress up. So these were our aims when we came up with the 21-day challenge. We wanted to increase the staff awareness and knowledge, as well as the service users' understanding of how to cook and enjoy healthy meals, improve the overall health and well-being of our service users, and to increase service users' cooking skills as well, to enjoy the social aspect as well as the health benefits. So we sampled 6 service users across our service. They were all selected with different levels of support. So we have people that have one-to-one care, high levels, moderate, or some that have welfare checks and just care as and when they need it during the day. This ran from the 8th of June till the 10th of August, and we did 3 rounds of the 21 days in collaboration with a dietitian.
So saying this, Lizzie started by gathering data from the track system, getting their weight since the first day they came into supported living. That's why we have those so accurate figures that we showed you before. We then went to the food preferences, helped them with shopping lists, meal plans, and we created food and fluid intake charts. We tried to make these as much personalized as possible. We include them in every single activity that we did so they would feel respected and dignified. So they would enjoy more the process of losing weight. Saying this, once we started the process, we were faced as well with the shared barriers and challenges. We started with the social activities. Our service users, they attend a lot of activities. These used to be parties, social gatherings. We have a room in the Le Grand Cortil that is called the Russells. We see our service users attending that room every day to eat biscuits, coffee with their friends. And we know that most of the social activities in Guernsey are based around food, which can be a problem. And of course, we don't want to take the joy of life out of them. But we could see that was a big barrier and was bringing a lot of problems to us. So our aim now is to try to make them understand that social activity is not only based around food, but based around different activities that we may do. And then we were faced as well with the barrier and even challenge, we can say, of exercise, because most of our service users had a very low level of exercise on their weekly planner, so this wasn't being facilitated. And then we had lockdown. With all the restrictions put in place by the government to help us all go through COVID, we could not get them out. And most of the times when we could take them out, they would refuse because they would be scared.
So another barrier that we faced was we identified through shopping receipts and also the food charts that staff were completing that the meals planned to last a week would only last 3 or 4 days. So this meant that extra portions were being consumed by the service users when staff weren't there to support them. And then after the 3 or 4 days, they would then go down to the canteen to buy breads and cakes to last them those 3 days. Or would even just snack on things and wouldn't ask for help to go and do a top-up shop. So this was a really useful thing for us to help identify areas of support as well. And we also found that our service user that has a non-typical sleep pattern would wake during the night and have snacks at midnight. And this created a vicious cycle with the sleep apnea, which is associated with excessive weight. And then her eating in the night would cause her to stay awake, cause excessive weight, and the cycle continued.
Another barrier and challenge that we faced was several times during the day, during the week, even the month, staff would offer the service users with healthier options, but they would often decline those. They would choose foods that will be full of carbohydrates or would be more unhealthy. As well, we identified a big lack of staff education regarding foods. Some of our staffs would not know which type of foods would have a spike on their blood sugars. So we had to increase the training and knowledge on staff, which is something that we already achieved, and we are still working on it. We then were faced as well with staff resorting more to takeaways and ready meals. This all to do with the lack of time. This is something that happens not only in supported living but across the service. Sometimes we will see that we don't have enough staff, or due to the business of the day we will take service users to appointments or to do other activities, and on the way back you will have very low time to do the meals, and it's quicker to do a ready meal or to go pick up a takeaway than cook a homemade meal or a healthier meal. This is something that we observe not only on staff but as well on our service users. They would often go to the takeaways and buy this food because it would be easier for them, and they did not want to cook. As well, we observed that most of them, if not all on our research, would often choose to have sugary drinks like soft drinks, or to have sugar with coffees and teas instead of have a sweetener, which is still a sweet, still not a very healthy option, but it's still a better option. We are now promoting them to drink more water, which is something that we didn't see before, but we are seeing now. As well to have, for example, a Ribena zero sugar, which is a better option than the full sugar Coke, for example. And last but not least, we had a service user that he would every day take his medication with a biscuit or a chocolate. We have now changed this. He will have his medication with a drink only, which will be a juice, which is still not the best option, but we're still working on it, or he will have instead a soft cheese.
So whilst we did have these barriers to face, we also did manage to achieve some things during this time. So we have increased the staff knowledge surrounding type 2 diabetes and things. They now know what food groups to offer our service users to help them manage that condition and to keep their blood sugars more stable. We've also increased the active support that we offer. So 2 of our service users find going to the supermarket quite overwhelming. So before it was just that staff went for them and they would pick things. But now we work in a more person-centred way, and we really try and find a strategy so that they can go into the shop, they can pick foods that they enjoy and really get motivated and feel more encouraged to make, enjoy that active lifestyle. We also have started batch cooking with one of our service users. So we have a lady that's very house proud, doesn't like to have staff going out to her every day and help her with meals. So instead we've decided that we'll do a batch cooking session with her once or twice a week, where we prepare enough portions to last 3 or 4 days, for example, of a healthy option. This means that she has her choices respected, but also means that we can control what food she's eating and have a staff support within that. Whilst we also prepare the meals, we have healthy snacks that we prepare at the same time. So we might boil an egg, or we might prepare an extra portion of vegetables, so that when staff go back to the office and the service user gets hungry, instead of reaching for a snack out of convenience that might be more sugary or a junk food, they have something healthy as an alternative to pick. And we also have signed one of our service users up to Weight Watchers. So she goes with her friend, and it's a social activity for her. They keep each other accountable so that they can keep it as an enjoyable thing, but it also keeps that healthy eating message in her mind more consistently and makes it a more enjoyable thing for her to do.
So now we're going to talk you through about one of our service users. Please meet Emma. Emma being supported by supported living staff for 3 years now. Me and Lizzie are actually her lead and key workers, so we often work with her and we know her very well. Emma receives a one-to-one support during the day. So as you can see, Emma is a wheelchair-bound service user, so she would, for every single transition that she needs to make to a different seat, to a different area, she will need equipment to assist her with that. So saying this makes it even more difficult for her to lose weight, something that for us neurotypical people would be easier to reach because we can go to the gym and do different types of exercises. She has been helping staff to develop a tool that is person-centered. I will tell you about in a minute. And Emma is well aware that she's clinical obese, but she wants to make a change to improve her health. So, unfortunately, Emma's weight has been kept stable since she came to supported living. She had some slight changes, but she's been keeping the same weight overall. Emma has worked with staff to move towards a healthier weight. So the tool that she created with staff, she created a menu book. In this menu book, she has the pictures of the food, the description of the food in case staff don't know how to cook this type of food, and then how much Emma likes this food. We then created as well a picture board, which is a visual board for Emma that you can see. The board basically consists on every time she has a healthier choice, she will have a green sticker, and that keeps her motivated because she likes to have the green stickers to make her feel proud of herself. We then introduced as well the charts where we can record if it was staff's suggestion, the food she's having, or if it's a service user suggestion. So this gives us an overall better understanding of what's going on inside of the flat. And then something that we are really proud of that we implemented is the swimming. Emma now is going on weekly sessions of swimming. She's a really good swimmer. She's doing amazing. Her flexibility and mobility in her joints has improved a lot. As well, it helped her a lot with the pressure relief on her body because she's sitting all day. Even us, when we're sitting for an hour in a chair, we start feeling pain. So we can imagine for Emma to sit 12 hours in a chair is really painful. Another thing that Emma knows and is really keeping her motivated not only to lose weight, but to achieve something else is that if she keeps losing weight, working towards her target of mobilizing, swimming, she even goes to the chair exercise classes. She joins some other activities that help her to move. She will be able to walk. So she has two targets, the losing weight and the walking, which she's really looking forward. So Emma, if you carry on, you can do this. Pass on to the floor.
So another achievement that we made, the thing that we found was most successful, was the use of the portion plate. This is mainly useful for the staff. So to show the visual picture of half a plate of vegetables, a quarter of protein and a quarter of carbohydrate, the staff can really use this strategy to support the service users. So even if they choose something that's quite pasta heavy, for example, they can put a side salad on it, and then they can feel more full, and that can help them towards their goal. So with this strategy, we had a service user lose 3 kilograms whilst we were doing the 21-day challenge. She lost 13 kilograms up to December, and actually at her most recent review, she'd lost 18.7 kilograms, which is almost 3 stone. So she's doing really well. So that's what we achieved during the time. We wanted to bring the 21-day challenge into 2021 and see what we can do from now. So we are continuing the education of staff. We now bring up at the staff meetings about how our service users are doing. We try and keep that message in our staff's minds so that they can be more cognizant of what they're giving our service users on a day-to-day basis. Several of our service users have expressed an interest in joining the Weight Watchers so they can all go as a group, and it can be a nice social thing and also keep them accountable. We want to involve their support networks, so that's their families and friends that are also working with us in MDT meetings and things, helping us come up with their food preferences that they might know that the service user enjoys that we don't, and we can incorporate that into their plan. And we also recently undertook a talking mat training course. So with that we can use a communication aid to decide what the service user wants to eat, and also they can identify what areas of support they want help with. So they might not want help preparing and cooking the meal every day, but we can personalise that to their specific needs.
Saying this, we have created the 21 activity yearbook. You can have a look when we finish the presentation. This activity year consists in every single month we will have a different activity, and we try to implement as much exercise as possible. We started by with a meal, with batch cooking, or cooking all together rather. They came all together, we cooked a healthy meal. They all enjoyed very much, so they understood that the social activity is not only about the food, but to come together and to enjoy their time together. Just recently, last Saturday, we went to Herm. Our service users made really healthy choices while they were in Herm, and they walked 6 kilometers, which is amazing for them. We then going to have different activities that are going to go out throughout the year. Next month, we're going to introduce Zumba on the gardens, and we're going to go to the beaches. So we'll have an amazing time. So it's all personalized for them and all to improve their lifestyle and their health. Lizzie will tell you about a different activity that we joined together with the 2021 activity yearbook. So if you could tell us about.
So with how successful our portion plate idea was, we wanted to join this to make it a social activity. So the 21-day challenge and the 2021 activity plan are joined together, and we are collaborating with Iris and Dora, who have given us a discount very kindly, and we're going to go to a workshop on the 8th of June. They're all going to paint a portion plate and make it personalised to them. They can put as many colours and vegetables and whatever food that they enjoy on there, and then they can use that when they're eating their dinners, and hopefully it will keep that message in mind of the healthy eating and provide a visual support to see what should be on their plate each night.
Thank you very much.
name's Mary. I work in Boatstrode. I'm one of the senior staff nurses here, and I'm just going to chat to you a little bit about my master's project that I did over the course of last year. Some contact details. The aim of the presentation today is just a brief background about the tool, which was developed by UKONS, which is the United Kingdom Oncology Nursing Society, a bit about patient safety, the UK pathway versus Guernsey patient pathway, the project itself and the results that I got, and about the tool itself, just a brief background. A bit about me. I worked on the medical wards, then I moved to Boatstrode 3 years ago, and I didn't really have much previous experience with oncology patients, only on the wards, so I had no idea how to assess an oncology patient if they phoned the helpline, or back then they were walk-ins, so I had no idea how to assess them, so there was no formal oncology triage tool in operation. At that point I was doing the master's pathway, so I got a chance to go to a conference in Glasgow by one of the drug companies paid for me to go. So it was a weekend away where there was a lady talking about the triage tool. She actually created it, so I took that idea and a few other ideas back to Guernsey and implemented them. I applied for a Safer Everyday Award in 2018 to see could I get the lady who created the tool to come over to Guernsey, and I won it. So the lady came over and we did a massive master's class where we had some district nurses, palliative care, A&E, and we had some people come over from the oncology unit in Jersey for the day. It was very useful. We created a working party from that to create the programme. And from that I did a service improvement as my final year management programme for the implementation of unique island-wide 24-hour oncology triage service using multidisciplinary team, because it was not cost effective to have our team doing it on a 24-hour basis. Patient safety. So there is increasing levels of patients undergoing treatment. There is an additional 30,000 patients per year surviving cancer for 10 years or more, so that's because of the new treatments and people on maintenance treatment as well. So new treatments is new problems, so there's a lot of new forms of treatment. So there's targeted therapies, immunotherapies, and they're given at the same time, or they complement the traditional therapy known as chemotherapy. And I suppose all this has actually stemmed from the NCEPOD report, which, although it was produced in 2008, it's still very much in date with all the practices that we used, where patients who died 30 days, well, there was an investigation where the number of deaths within 30 days of receiving chemotherapy were due to complications up to toxicities of the treatment itself. So that's where this report stemmed from. These are some of the patient safety. So this is some of the side effects that patients can receive from all the treatments that we do give them. They're not very nice, some of the side effects that chemotherapy and immunotherapy and the targeted drugs can give. We assess all these if a patient does contact us or walk in with an issue. So going on to the UK pathway versus the Guernsey patient pathway. So in the UK, I think it's very important to highlight that patients have free access to all these services. So they can attend the GP or district nurses. They have access to emergency services, so that's your ambulance. They have access to 24-hour advice lines, which is run by the oncology unit itself. Some are operated by Macmillan nurses and some are operated by local pharmacies. They also have access to urgent care, so A&E or an AMU unit, and also the bigger oncology units operated in university hospitals have acute oncology services. So moving to Guernsey, we don't have 24-hour advice lines or acute oncology service. So we do have access to GPs, we do have access to St John Ambulance, and we do have access to an A&E. So fortunately with this project we have set up where if a patient does attend A&E and their side effects is due to a treatment, they don't actually have to pay, but that's up to the A&E business manager to decide. Myself and our team created a unique Guernsey patient pathway. So during the weekdays, patients do have access to both road nurses, palliative care and GPs for an assessment if they are ill. They can phone us. At the weekends, patients can phone the district nurses or A&E and out of hours likewise. So this is important. We also give patients, self-management strategies, so their own patient empowerment and what they can do. It's important for them to report symptoms, so what symptoms they need to report and seeking advice. And we do give patients, this is what I took back from Glasgow as well, their own patient record book, where there is a triage section at the back of the book that they can assess themselves, something similar to the ones that we use, except with basic terminology and what they should do if they get a certain symptom, or should they be going to A&E, or should they be calling the department. So yes, this is the toolkit itself. It comes in a book that has just got a lot of details in it, how the tool was created, etc. So this the toolkit is used for anybody undergoing chemotherapy and up to 6 weeks post-treatment, because you can still get side effects, and patients who are in Guernsey, this is patients who are receiving immunotherapy and up to 12 months after completing their immunotherapy treatment, because they can still actually get side effects of immunotherapy up to a year afterwards. It's also used on patients who receive radiotherapy and who have an immunosuppression condition such as acute leukemia. It's important this is used just on adults, not on children. There is a separate one for kids. The toolkit aims basically to help the nurse or whoever is assessing the patient at all stages of the trials process. So that's whenever they're to collect their contact and data collection, the actual assessment itself, and to find the definition of the problem that the patient is phoning for, the appropriate intervention and action. It's quite important to remember that sometimes patients phone with the big problem, but they leave out all the little ones, so it's quite important that we assess the patient as a whole. So we do have a list of questions that we do ask everybody with this tool. The tool provides a simple and reliable assessment process, so it's a consistent assessment that everybody is getting. It's safe and understandable advice that we provide the patient, and also it helps us in the department. It uses a communication tool and record keeping, so we can put the document into the nursing notes so someone else can go and see what we actually did for the patient. It can be used as well as a competency-based training tool, and it's also very useful in auditing. The toolkit itself, I don't know if you can see it. It does come in a pocket format, it's not just this, it does come in something that we can keep in our uniforms. So it is based on the NCRI-CT CAE common toxicity criteria, so this is more commonly used by doctors. It's a risk assessment tool used to grade patient symptoms. It should only be used as a guide, so you should also use your clinical judgment what you think. It highlights the questions to ask the patient and establishing the risk. It leads to the nurse to a decision-making process and a robust triage, and it's also used as a cautious tool, so it identifies if an early intervention is actually required. So we are asking the patients some questions. This is the triage assessment sheet, so whenever a patient phones or walks in, we always take their details, their diagnosis, in the patient's own words the reason for the call, and then we have got a set of questions to ask the patient, so it is actually a consistent assessment. So if you haven't really asked the question, if you haven't filled it in, it hasn't really been asked, the question hasn't been asked. So it's a standardised assessment tool that will support the triage process. It's a guide and a checklist. It's a communication tool to rely an accurate picture of what the problem is and what you have done. It's also a record process for quality, safety and governance reasons. So it's a scoring system. I'm sure you've seen when I held it up, you've seen a lot of red, amber and green. And so that's what a patient can score. Same with the Manchester triage in A&E area. So any patient that phones, say with, for example, chest pain, it's obviously going to be an urgent matter, so you should be asking the patient to attend A&E for an urgent assessment. If a patient scores 2 or more ambers, that is a red, so they should be also escalated to a red, so they should be also asked to go to A&E or to Bulstrode for an urgent assessment. If a patient scores 1 amber, that patient should be followed up in 24 hours. However, it's important to inform the patient that if their condition deteriorates or if they have any concerns, to phone us back or to phone A&E back or the district nurses. A patient who gets a green score should be instructed as well to call back if there is any concerns. We do follow up any of the patients who score a red or an amber. We do follow them up in 24 hours if we think that we do need to. So yeah, there's lots of documentation for different areas. So when I did last year when I implemented the tool, I went around different areas and did teaching practices, teaching sessions and implemented this documentation. So it's a pocket guide, the first one, that's our assessment sheet, and then that's a logbook for instructions how to use it. This was implemented by primary care GPs, district nurses and palliative care, not really yet the ambulance, and because of COVID we haven't actually had a chance to do that. Alderney hasn't implemented this yet either, but it will be in due course. So this is the documentation that A&E and Bulstrode use. We do actually, the first section is the acute oncology initial management guidelines, so that chats you through what you should do in terms of diagnostics, what blood tests etc. to do, and then the last bit is the actual triage and the assessment log sheet. And this is what the patients get. So whenever a patient comes to Bulstrode, we do an education session with them and provide them with the book, so they have their own empowerment of what they actually need to do. We have found, since we have implemented this, our calls and walk-ins have lessened, which is what we're trying to do. So yeah, promotes empowerment. So I'll just chat to you now a little bit about my master's project. There's 4 objectives in the study. So the first objective is to implement a 24-hour oncology telephone triage service using oncology, palliative care, A&E, district nurses and GPs in Guernsey. So yeah, after we had the massive masterclass day, we created a working party. So a representative, mostly a senior representative, came to several meetings over a course of a year. That was quite important to get their views on what we should be doing to implement the tool, also how we could support them as a unit. So I did teaching sessions in each area over the course of October to February, so October 19 to February 2020. So I implemented it in each area separately just to identify if there was any issues. So I did it in A&E first, and there was very little issues then to district nurses and palliative care, and they could always phone us if they were having any issues. Unfortunately, some of the areas COVID had a massive impact on the implementation and the continuous communication, because pandemic takes precaution first. So that was the first objective, which we did achieve. Objective 2 was to explore patient engagement on the newly implemented telephone triage service over a 1 month period. After this objective 2, 3 and 4 was all based really in Bulstrode, not in the other areas. So it was important before we implemented the tool to actually get a baseline on the pre-existing activity. So each member of staff in Bulstrode had to complete a small tick box questionnaire on all the activities. So if a patient walked in, they had to, with a concern or a symptom, we had to complete a small tick box questionnaire. So 38 patient activities were logged over a 15-day period. So that goes from phone calls to walk-ins, etc. So walk-ins that were discussed with a doctor was 8%. Phone calls referred onwards, so that was either to A&E or to their GP, was 16%. Walk-ins and advice given was 29%, and phone calls where advice was given from a nurse was just 42%. So post-triage, we have 2 phases. I'll chat to you a little bit later why we had 2 phases. So phase 1 was supposed to be a 1 month period, so it was supposed to go from the end of October to the end of November. However, there was only 6 triage assessments completed. So to collect more data, I decided to extend the audit for another month, where 18 UConn's triage assessment tools were completed. In phase 2, which happened after Christmas, so February to March, 10 triage assessment tools were completed. I broke this down further, where I looked at phase 1 and phase 2. In phase 1, there was 16 phone calls accepted for patients phoned about symptoms and 2 walk-ins. And in phase 2, we had went back to 5 phone calls and 5 walk-ins. As a unit, we are trying to move away from walk-ins because of the busyness of the unit, and not always having someone available to assess a really poorly patient. We also don't have the monitoring that they need. So the actions taken, so they were split into categories. So a GP visit was advised or seen by doctors in the oncology unit. A&E visits was advised, advice was given by nurses, and advice was given by a doctor. So that is where a patient had phoned and a nurse gave them advice from one of the consultants. Data comparison. So due to the decrease in calls in phase 2, significant reduction in nursing advice was given to patients. There was also no advice received from the consultants. There was fewer referrals made to A&E, but because of that, there was significant increase in the walk-ins in Bulstrode. So that meant that there was more patients seen by their oncologist in the unit. GP referrals remain similar. So if we referred someone to their GP, they have to actually pay for it. So that's it. So objective 3 was to evaluate record keeping and the quality of advice provided against the UConn's 24-hour triage assessment toolkit during a 1 month period, or until significant data is collected within the department. So record keeping, I did this in phase 1 and phase 2. So in phase 1, the record keeping was just satisfactory. So all the assessment tools were photocopied, and I sat down and I assessed them all. Unfortunately, we got 89%, which is a satisfactory mark. But there was simple errors made, so with simple things such as medical history absent, toxicity table was partially completed, and the forms weren't signed. So I did go and ask the members of the staff how could we actually improve on this. So they said that they would like the shift coordinator. So we do have a shift coordinator every day who deals with the unexpected. They're not allocated any patients. So the shift coordinator was responsible for assessing patients' toxicities. They also wanted a clear flow chart with instructions on what to do on the actions required following the assessment. So if a patient phoned Bulstrode they required origin assessment and there wasn't a consultant around. I have the A&E contact details and email address, so we could email the log sheet to A&E with extra details regarding the patient to make A&E aware that we do have an oncology patient on the way with query sepsis or nausea and vomiting. So because of this, the shift coordinator who had time to complete the assessment form, phase 2 got a result of 100%. So I have broke this down to quality of advice given. When I looked at the red, amber and green, I could see what sort of advice was given to patients. So in phase 1, this was based on 18 activities, so 50% of people who phoned required origin assessment. The people, 6% in the amber, they were the ones who got 2 or more ambers. That is a red, so actually 56% of people required origin assessment. In the amber zone and the green zone, so amber was 11% and 22 in the green, so everybody in the amber zone were given a 24-hour follow-up. In phase 2, this was based on 10 activities, so 60% of people required origin assessment, 30% who got a score of 2 or more ambers, they also required origin assessment. The 10% amber were followed up in 24 hours and no one there scored a green. So taking the red triggers, or this includes as well the 2 or more ambers, so of the patients that required an origin assessment, various actions were taken. So not everybody was actually sent to A&E. So some patients were discussed with an oncologist or assessed within the oncology department due to the availability of a specialist at the time, rather than referred to A&E. This also was affected by the increase in walk-ins in phase 2. So if someone walks into the department, can't really send them off out the door. So four patients who called for telephone advice who required urgent assessment were not referred to A&E or an oncology department because the nurses used their own clinical judgment in the circumstances, and justification was provided on the log sheets. So just to point out, the pie chart in phase 2 is the details in it is incorrect. So the red trigger actions, that's then listed in phase 1, and in phase 2 we had 11% of patients referred to A&E, 56% were seen by a doctor in the department, 22% was when a nurse used their clinical judgment and referred them to their GP, and 11% were seen by a doctor in the clinic. So in the situations where the nurses used their clinical judgment, so in phase 1, one patient contacted the department who was already on their way to their GP. A nurse assessed their symptoms and they scored 2 reds and 4 ambers, which is known to be an urgent assessment. So the patient attended their GP for a clinical assessment and actually was referred onwards to A&E and admitted with urinary sepsis. Another one in phase 1 is where a patient scored 3 ambers. So the side effects experienced by the patient were not actually from their treatment, it was ongoing for 4 weeks. So we were sent them to their GP because their ongoing symptoms for 4 weeks, they weren't just from the treatment. In phase 2, a patient phoned and received 2 red and 4 amber in the assessment. This particular nurse received advice from a senior staff nurse as it seemed like a symptom of a virus. So the patient was told if the symptoms persisted to attend A&E. This patient was subsequently followed up in 24 hours and her symptoms were okay. The final one is where a patient received 1 amber. Although it wasn't a new symptom, the patient was going on holiday, so we did take a bit of precaution when we sent the patient to their GP where they commenced oral antibiotics. So yeah, this tool is really a guide, so if we find that someone scored an amber or green and we weren't too sure, we would still get them up to check their bloods out, still if their temperature if they don't have a temperature and they're clinically, they don't feel well, it's always important to check their bloods just in case they are neutropenic. So yeah, and then things where patients received advice from a nurse's clinical judgment, all correct advice and referral instructions were followed in all 4 of the triage assessments completed. So yeah, there was no per patient outcomes. The nurses that utilised their clinical judgment documented it on the action plan section. Fewer triage assessments were completed in phase 2, and there was a decrease in referrals made to A&E in phase 2. So the final objective of the project was to actually to explore patients' satisfaction on the service provision using a questionnaire over a 1-month period. So I did this on phase 1 only. So in phase 1 we had 18 log sheets completed, 14 patients were identified as appropriate candidates to complete the questionnaire. 4 people were excluded due to technical reasons and will cause unnecessary distress to them and their families as they approach palliation, or some patients were already deceased. And 3 patients had 2 triage assessments completed during the 2-month period. We had 11 patients in this section. I sent out questionnaires with an information letter and free postage envelope, and we had 100% response rate. The questionnaire had 9 questions on it. So I'll just briefly go through this with you. So did a staff member tell you what to do if you felt unwell? 100% said yes. Did a member of staff tell you what side effects should be reported? 100% of people said yes. If during your treatment you felt unwell, was advice available to you? 7 people said yes, and 1 person said it wasn't necessary. Question 4, where did you seek advice if and when you were unwell? So that was where people contacted or attended A&E or attended Bulstrode. 1 person said other, not really too sure where they received advice. How satisfied were you with the advice given? 7 people were satisfied, 1 person was indifferent. How satisfied were you with the nurse's level of knowledge? 8 people said they were satisfied. Did you feel the side effect table in the record book helped you know when to seek advice? So 6 people said yes, 1 person said to some extent, and 1 person said other. I think the 1 person who said other was a patient on maintenance treatment who didn't receive a book, because we only really started to roll them out when I did my project, so they perhaps didn't receive one. What improvements, if any, do you feel we could make to the telephone advice service? So it was all good things, and the only thing was that people wanted the oncology unit to make the telephone advice service 24 hours a day, 7 days a week, which unfortunately is not possible. So yeah, it was all good feedback. I left a section for other comments, which were all good. The only thing was that 1 patient who was on immunotherapy asked for an immunotherapy specific book. Unfortunately, there isn't one of them. The charity itself spends a lot of money creating the books, and it is also for an immunotherapy patient. There is questions in there, especially for their conditions and what to look out for. So yeah, the UK Cancer Research Charity won't be updating the books. I did pass on, however, the comments to the charity. Limitations. There was some limitations to the project. So as a Plan Do Study Act, service improvement to serve the oncology population in Guernsey. So it's a small population on the island, so therefore it was a small sample size. It was just based on 1 hospital only and focused more specifically on the oncology department. Numerous cancer patient groups don't have access to a CNS, so for example head and neck patients and lung cancer patients, they don't have access to them, so we are their main support network, or the palliative care nurses. Due to the population size in Guernsey, we are very familiar with our patients, so this could have had an influence on the questionnaire returns and the responses that we got. During the project, it was difficult to improve the service because of the cost of people attending their GP and A&E, which makes things a bit more difficult in Guernsey. In Guernsey, we don't have an acute oncology service. We don't have junior house officers or senior house officers. COVID also had an impact on the project, especially in the communication. So once COVID came, we couldn't really implement some of the service, and communication to the MDT kind of disappeared as well. The oncology team did benefit from it though, as we received information on other services or how we could improve on our service, so it was useful to sustain our service in the future. And this is the flowchart that is now above all phones in the department, and also is available to GPs, the district nurses and A&E of what to do whenever a patient receives a red, amber or green, and what we should be doing, or how A&E can ask us to follow a patient up in 24 hours if needs be. So it's just a Guernsey-fied algorithm for the UK triage tool. So the conclusion. So the service improvement was achieved. It achieved its aims and objectives. I did successfully implement a 24-hour trial service utilising multidisciplinary teams in Guernsey. The audit accomplished quantitative data on all the trials log sheets completed in phase 1 and 2. We also explored patient engagement and evaluated record keeping and the quality of advice provided. The results improved in phase 2 following the necessary changes, and that was also to sustain our service. Although a small sample size, the 100% questionnaire return rate provided maximum quantitative data which enhanced the quality with the qualitative data on the satisfactory service provision reported by patients who utilised the triage service. The service improvement and previous research conducted by larger populated areas in the UK and in Ireland highlighted the necessity for a 24-hour triage service for oncology patients. The implementation of the Cancer Research UK treatment book it's also proven successful. We have found that our number of calls and walk-ins have lessened since we have implemented this, and passing patient comments found the book very useful. So a lot of our patients on maintenance treatment now find the book useful as well. Further research is required on patient empowerment strategies as a cost-effective method to sustain oncology service and to improve patient outcomes on managing toxicities. So the next step, during our masterclass we had some paramedics from the St John ambulance they're quite keen to implement a similar service. So I was in talk with a UK ambulance trust who actually utilised the tool, but unfortunately COVID cut down that communication in the UK. So we will get that back up and running at some point. It will be beneficial, as it would mean that all our oncology patients on the island are getting a consistent assessment, whether that's by a paramedic or attending A&E. And word of mouth has led to requests for teaching sessions on the tool from other areas, including the hospice, because a lot of our patients goes for respite to hospice after receiving chemotherapy, and also Jersey, our sister island, was asking for some education sessions as well. I will continue the education and training with the relevant MDTs, but hopefully in due course an audit occurring in some of the areas. During the pre-treatment discussions we do continue to educate our patients on how they can assess themselves using the book, emphasising empowerment and self-management of symptoms, and in partnership with the governance team and the oncologists, lead cancer nurse and oncology nurses, hopefully we will devise a policy recommended by UCONS, outlining the roles and responsibilities for everybody, reduce the risk of liability, and highlight the necessity for ongoing monitoring and audits. Anybody any questions? Thank you for listening.